Is that your text, Barb, coming through?
Is
So funny.
my frog. That's the only way I hear it. For clinical or whatever. Well, I used to get clinical. Now we, of course, have a special, a special HIPAA protected.
Sure.
Well, it doesn't matter. Are we muted? Yeah,
I have no idea anymore.
we're muted from what's going on. Yeah.
Yeah, we are currently not going out to attend.
Yeah. We're in I know a room. I did like 3 of these momentums last year, so I'm sort of remembering.
Yeah, we are a little more than 5 minutes out before I start the webinar and our video playback today.
Right. We don't do anything though for 40 minutes or so.
Correct. You'll just mute your microphones, turn off your videos, and watch the presentation.
Okay. Oh, we should mute for sure then. Okay.
Okay, so I think we are now all connected via text, Barb and Aaron.
Just to clarify, we're not on video when the tape is going, are we?
Correct.
Yeah,
we will
okay.
just be seeing the panel labeled playback.
Gotcha. That's what I thought, because to sit there still for 40 minutes is hard.
For sure. Yes. No, I'm not here to torture you today.
It's enough torture having to listen to it and see it, honey.
And just to clarify, just in case I added any confusion, during the Q&A portion, though, everybody will have their cameras and their microphones on and then be going out to the attendees live.
Another question, the plan for us who are on here as members of the GSA staff was to put a link to the participant bios in the chat. Will I still be able to do that?
I believe so, but it would be for our participants to read out during.
Okay, this is a web link, which is like a PDF document with like expanded bios of everybody.
Oh, got you. I believe once we start the webinar, you will be able to post out to the attendees. Yes.
Okay, I'll give it a try.
1 minute out until playback. From 30 seconds. Beginning webinar in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello, everyone. Welcome to our GSA Momentum discussion. Today, we're going to talk about risk communication for vaccine preventable illnesses, addressing concerns facilitating behavior change. I'd like to introduce our panelists, Dr. Barbara Resnick. She's a professor at the University of Maryland, and Dr. Aaron Scherer, who's an assistant professor at the University of Iowa. My name is Robin Jump. I'm at the Lewis Stokes Cleveland VA in Cleveland, Ohio. So let me start off with our first question, pardon me. So the problems that we're seeing right now in nursing homes are reflective of what we see sometimes in the community with some vaccine hesitancy, sometimes more among staff than among our residents themselves. And there's clearly a benefit to vaccines, yet we see some low uptake of those. So I wanted to find out from both of you, what are some approaches that we can use to stimulate a discussion about vaccination with older adults? How do we work on communicating and facilitating the actual end result of getting a needle in somebody's arm and then offering the protection from vaccine preventable illnesses? So we're going to talk about risk in general and also talk about some of the views about vaccine illnesses, especially influenza and RSV, as well as COVID, of course. And we'll also talk maybe a little bit about some of the different practice settings that we have within that broad spectrum of long-term care. So let's start with influenza vaccine, which is an oldie but goodie, and we've been used to this because we've had it for over so many years. What approaches should we be using to get people to accept the vaccine? What has worked in the past? Aaron?
Yeah, so in terms of risk communication strategies, there actually isn't that much research in this area. And part of the challenge with communicating about risk in adult vaccines is that most of the emphasis and research has been on childhood and adolescent vaccines. So for example, it wasn't until 2018 that we had a scale that measured vaccine attitudes about vaccines recommended for adults. Which is part of the reason why we are so unprepared for dealing with COVID, is because we really haven't done research in kind of our standard fare of viruses like influenza. Some of the things we do know is that things like reminders and patient education sessions tend to be effective at improving influenza vaccine uptake. But again, there has been a lot of research looking at whether the specific content of those reminders or the education sessions have much of an impact. On kind of a cautionary note, there's some evidence that attempting to correct myths about the flu and influenza vaccines can be effective at correcting the misconceptions or the myth. But among people with negative vaccine attitudes, it can have kind of a backfire effect where it corrects the belief, but actually reduces their interest in getting vaccinated.
That is very interesting. I think I've heard that about COVID, but I didn't know that we knew that about flu as well. That's very interesting. So, Dr. Resnick, what are some tricks of the trade that we can use to optimize people to accept vaccines, especially if we have to dispel myths?
So first I got to tell you all, I read in the health section, I'm in Baltimore, Maryland. I read in the health section this morning that there are 27 vaccines available and about another 15 in the making. So I think that just reinforces how important and exciting really this area is. Not all vaccines are appropriate for all of us because they all have different ages. But I take a very theoretically based approach. And so I'm going to take a moment and bore you with the theory. But at a bigger level, we think about this, the socio-ecological model, and think about intrapersonal factors, things within us, our beliefs, as you addressed, Erin, maybe motivation, our health behaviors, those types of things. Interpersonal interactions, the verbal interaction, and I'll talk more about that. The environment that we live in, how easy it is to get immunized, and policy. Bottom line, guys, make it law and you change behavior. The other thing that I use is a self-efficacy based approach. Self-efficacy essentially says, if you believe you can do something, you're going to be more likely to do it. Now, it's not hard to walk up and get a vaccine, but more importantly with self-efficacy theory is outcome expectation, particularly for older adults. What do you believe is going to happen with that vaccine? If you believe it's going to protect you, then it's going to be a lot more likely you'll get it. If you believe it's going to kill you, there's not really a good chance. And if you believe God knows what else, it's not going to happen. There's ways that we can increase your outcome expectations and your self-efficacy. That's really with, I think, appropriate education, whether it's myth busting or not. I think it's really finding out what the person believes and getting at that, because we really need to know where somebody's coming from. And you sometimes need to dig deeper than just hearing, I don't have the time to get a vaccine, or it's not easy. I mean, what's the real reason? And sometimes you have to prompt people. Are you afraid? What are you afraid of? So really finding out why. Verbal encouragement, somebody they trust, constantly telling them, you know what else constantly telling somebody says? I care enough about you to give a hoot whether you get vaccinated or not. Role modeling, being the one to stand up there, may help some people. And then a really important thing we forget about, and I think COVID has brought this out a little bit, is getting rid of the unpleasant sensations or acknowledging them. And I bet you there's a lot of people that don't want to get a COVID vaccine because they heard from their next door neighbor, it hurt, and they felt crappy the next day. And of course, we always try and remind people, you're going to feel pretty crappy if you get COVID too. So those are some of the really common kind of tricks of the trade. And then I think the most important thing we can do is never stop asking. There is a tendency to ask once, and if somebody says no, to never ask again. That, to me, Erin, is risky communication. It's constant communication we need because it shows constant caring. Just some tricks of the trade.
Thank you.
Yeah, just to follow up on that, we know
So-
that, a strong
Yeah.
provider recommendation is one of the best things you can do
Right.
to improve vaccine uptake. And not just recommend it, but have it available as well. Obviously, if you recommend it, but don't have it available, it makes it challenging, so.
So Erin, I want to hear more about this, the vaccine acceptance scale for adults. This is a new one on me, so can you tell us a little bit about what that is and what we know from it so far?
Yeah, so the original scale was called the 5C scale, the 5C psychological antecedents of vaccination. It was developed by Cornelia Beck, who's a vaccine attitudes researcher in Germany. But essentially, she argued that you can boil down, whether people get vaccinated or not on 5 C's. So there's confidence in the vaccine in terms of its safety and efficacy. There's complacency about the disease itself. So even if you think the vaccine works, you're not, sufficiently concerned about the disease, you're not going to get vaccinated. There's constraints, which tend to have to do with perceived, barriers, in terms of access or time constraints. There's collective responsibility, which is, this idea that, infectious diseases are kind of a unique public health risk in the sense that your behavior as an individual affects the risk of other people, and their likelihood of being affected by it. And then I'm trying to remember the 5th one.
It's okay if you can't, because I know that wasn't off the top of your head, which is amazing. And I appreciate you taking the time to talk through these. It'll come back to you maybe later during the conversation.
Yeah, but one thing I'll say is that what they found is that different of the different C's tend to be associated with different have different differential effects depending on kind of the age group. So for childhood vaccines, most of people's willingness to vaccinate their kids is focused on their confidence that the vaccine is safe and effective, whereas for adults it tends to be focused more on that complacency. So it's the extent to which you view the disease as being something worth getting vaccinated for or not.
So Erin, thank you for that great answer. And I know I put you on the spot with trying to remember 5 C's. Did the 5th one come to mind?
Yeah. Now I'm thinking about it. It's calculation, which has to do with, how much information people want to look for with vaccines. And somewhat surprisingly, but maybe not, is that people who have lower vaccine confidence tend to be higher on this calculation metric, where if you think about it, people who are vaccine hesitant tend to look for more information than people who are confident about vaccines. It's just that they tend to look in the wrong places, which is where the problems come in.
So Facebook and the internet in general perhaps may not always be the most reputable sources. Okay.
Right. Yep.
So Dr. Resnick, building on that, and also about what you talked about earlier with outcome expectations, how do we use this information to help us improve our vaccination rates for COVID?
Well, I like to take the positive approach and really focus on the benefit. And again, finding out what stops that individual. Erin, it may be going around and finding all the negative tidbits you can and really discussing those comment by comment and meeting. I mean, this is really sometimes a one-on-one individualized approach. I have to tell you, here in my own facility, anybody that refused to get vaccinated had to come talk to me. And I can't tell you how many people through those one-on-one discussions I was able to get to say, okay, I'll go out to my car and get my license and my insurance information or whatever and get vaccinated. So it was really hitting those individual points. I think some of the things with outcome expectations as well is really making it very simple and clear. Simple in terms of what you need to do to get vaccinated and what it's going to do for you, and just repeating it, making it accessible, clear, easy, and beneficial. Really any vaccine, but COVID as well.
Yeah, I actually completely agree with Barb regarding it's not very effective to just go after the misinformation. in the consulting I've done, I've encouraged groups to try to build vaccine confidence rather than work on dispelling or correcting misconceptions, because it's like, I feel like, especially with COVID, it's like playing whack-a-mole. The minute you kind of get one down, something else pops up. And so I think it's really about explaining clearly, the vaccine development process and how we were able to get the vaccine so quickly. But the reason why they're safe, I think that's kind of where we dropped the ball is people have an intuition that, the quicker something's developed, the less safe or reliable it is. And, kind of the standard public health official response is, well, we didn't skip any steps and it went through the, all the FDA process. And that doesn't, address people's intuitions that, well, how is it that you're able to do it so quickly without skipping steps? That's not often explained very well. And one point I'll make too, I completely agree to keep things simple, but there's also, you have to be careful in the sense that, for example, we tend to like to use verbal labels to describe like the likelihood something will happen. So we might say that, it's an uncommon adverse event for a drug. But the problem is there's wide variability in how people might interpret that phrase uncommon. So as an example, the European Commission has verbal risk labels, and they're associated with certain percentages that an adverse or probabilities that an adverse event will happen. But in like one study, for example, when they said, oh, the risk of upset stomach, it's an uncommon side effect. For participants told as uncommon, 68% of participants, overestimated the likelihood they'd experience a stomach ache if they took the drug, and were less likely to want to take the drug compared to when it was presented as, an upset stomach occurs in 400 out of every, 100,000 people who take this drug. Another thing that we try to do that to simplify things that can sometimes backfire is using relative risk or relative improvements. So we might say that, oh, this drug, is 5 times better than the other drug, even though the actual absolute difference might be very small. And so we have to be careful that we don't, unintentionally exaggerate how effective something might be, or the risk, the extra risk that a certain factor might have for people.
So keeping the messages in simple terms that around concrete numbers.
Yeah, and it's best to use frequencies. So saying, X out of 100 or X out of 1,000. And then, when you're comparing, then you can make that comparison very easy by keeping it on the same kind of scale. And people are able to better understand kind of numeric risk better when you use like icon arrays or pictographs. So, you see these often where you have like 100 people and they'll show you like, this many experience this and this many don't. And those are effective because they not only do they help, basically people who are good with numbers, it doesn't hurt them, but for people who have a problem or difficulty understanding using numbers, it tends to be a much more effective method at communicating risk information to them. It's just easier to process for people in general. So
yeah, you raised another important point, and I think that's one of being honest and preparing people, and particularly as we move forward with the COVID vaccine and discussions, are we going to need this every year like a flu vaccine? I think it's letting people know what the potential outcomes could be. Again, reminding everybody there's a lot of outcomes if you do get COVID, but the arm soreness, you may have some achiness. I mean, whether you give the numbers or not, letting people honestly know that is so important. And then one other really important piece that we haven't addressed that, again, you know, with older adults is critical, and that's the altruistic aspect of immunizations. And, you know, we do that a lot with Tdap in older adults. You know, this is to protect your great grandchildren, right? But with COVID, it's also reminding people this is to protect your family and your friends as well. And that is sometimes more motivating for people than anything else. So I think those are kind of two additional motivational tricks of the trade. But honesty and trust is critical here, because the immunizations are not always a one-time and done.
Yeah, and I think one of the challenges though about being honest is, you know, especially early on in a emerging infectious disease outbreak, we have very little, you know, concrete scientific knowledge. But, you know, public health officials have to make recommendations for risk mitigation strategies. And so there's some research that I've been involved with looking at, you know, what effect does communicating uncertainty have on people's, you know, interest in being vaccinated, or different ways of, you know, talking about uncertainty so that you don't undermine people's confidence in you. And so one study we've done with COVID has shown that describing, let me see if I can get this right, describing uncertainty, but then highlighting the hopeful aspects. So talking about, you know, we don't know much now, we'll know more in the future, be able to make better decisions, and, you know, we'll be able to address COVID better, is actually probably one of the best ways to communicate about uncertainty. Because if you just say, oh, if you just try to normalize it, it seems like that's not very effective by saying, you know, this happens for every outbreak. We don't know very much in the beginning, and then we find out more. That tends to undermine people's confidence, but adding that kind of aspect of optimism seems to be help offset that a little bit.
Yeah, and that's being honest.
Yep.
I've been telling people we're all going to find out together soon. So that tells us about COVID. We talked about influenza. Some other vaccines that older adults are recommended to get include shingles and also the pneumonia shot, which is now the pneumonia shots. Let's talk about shingles first. What have you heard about, or have you encountered in trying to do risk communication around the shingles vaccine and preventing a shingles experience?
I mean, on my end, in terms of risk communication, shingles has basically been ignored as far as I know. I haven't come across, I don't think, any literature or research exploring how to communicate about shingles. Similarly, pneumococcal, there's not much that's been done on communicating about it. Most of the work that's been done on those is focused on, you know, factors associated with vaccine uptake, and it's usually just demographics. And very rarely do they look at, you know, psychological characteristics like risk perceptions and things like that. And there's also very few studies that examine more than one vaccine in a single study, which makes it challenging then to know kind of, are there things that cut across vaccines that you can emphasize, or is it specific to each vaccine? And actually have a KO1 through National Institute on Aging right now to explore those kind of issues of, you know, where things that may be consistent across vaccines that you can emphasize with older adults. Yeah.
Dr. Resnick, what are your thoughts on communication on shingles vaccine?
Yeah, I think each vaccine in many ways needs to be addressed separately, because in many ways the issues are separate, both in terms of access, getting the vaccine, the impact of the vaccine, and the concerns around the disease. And Erin, you raise a really sad and unfortunate point, but not enough older adults have been immunized for shingles. And boy, oh boy, we all know it's devastating if you get it, and we know who gets it. So it takes a lot of work around that vaccine because of some of the challenges we know to actually giving it. I've had some really good success in my own clinical work by, after years of work, getting patients and families to advocate and say, we want everybody immunized, and brought the vaccine to them. That takes work, I'm not going to lie, but that's the level that we're talking about. We have an interesting situation, Robin, you raised the double pneumonia vaccine, or two different options. And it gets very confusing for people because, as many of us know, the recommendations were just changed. So what is one to do? And I think this is one, and Erin, we kind of both have flip-flopped a little bit about addressing this at the community level versus the individual level. And a little bit of both needs to be done. But I think getting, again, accurate information, access opportunities. I think the really exciting thing about COVID is that we're talking an awful lot more about immunizations, and have the opportunity to throw in there. And I say to all of you, if you haven't gotten your shingles vaccine yet, you should, if you're eligible. And pneumonia, again, is very much, there's one option if you're of age, but the second pneumonia vaccine, again, is a personal discussion with your healthcare provider. So
Right.
those are, they get tougher, but I do think, and Erin, it'll be exciting to see what you find in your research activities, but often these need to be individualized discussions. And for those of you out there that are healthcare providers, I recommend you do this during the annual wellness visit.
So the PPSB 23 is currently a shared decision-making prospect, which always struck me as a little bit odd, because all that we really do at this point in medicine is supposed to be shared decision.
Shared decision making.
Yeah. So, but I do hope for some simplification of the pneumococcal, so that the pneumococcal immunizations will be coming up soon. So, having talked about influenza and COVID, a little bit about shingles and pneumonia, Dr. Resnick, you opened early on the conversation about some upcoming vaccines that you think are coming down the pipe. So, what are some of those?
Well, I know there's some discussions about a vaccine for RSV. There's also discussion about vaccines for malaria and tuberculosis. And I mean, some of these things, while they may not impact us as much depending on where you live, they're amazingly exciting. But I also think about those 27 shots, you could be very busy. Although it's 27 shots throughout your lifetime. So we need to look at it that way. But I think there's new opportunities for those who make vaccines, because there's different ways of making them. And it's funny to think about for all of us. Can you imagine never having a cold again? Like, that would be a great winter. Never having the flu again, never having COVID. And if all it takes is a shot once a year, hey, that's worth it. So I think there's a lot that's quite exciting coming down the pike.
So as we think about some of the new vaccines that are going to come out, so I think about RSV a lot, because that's almost as bad as influenza is in terms of death, especially for older adults in nursing home settings. How should we anticipate, or how can we learn from COVID and influenza and start framing the discussion to improve vaccine uptake around this, what will be a new vaccine? So Aaron, do you want to start off with that?
Yeah, I just want to highlight an anecdote really quick before I answer. I was watching a discussion on vaccine attitudes and vaccine hesitancy, and it was all pediatricians and for the panel, and I asked the question, and this was somewhat snarky, somewhat not, but mostly serious, but I asked, 90 to 95% of morbidity and mortality for vaccine preventable diseases is with adults, 18 and older. And well, mostly it's 50 and older. Why is it that we spent so much time on childhood and adolescent, but then neglected adult vaccination? And I just got deer in the headlights looks from the panelists. And so I think, part of it is trying to preemptively identify kind of the concerns people might have. This gets back to something Barb mentioned earlier is we know people are probably going to be concerned about the safety of the vaccine, depending on the speed in which it's developed, or, if it's a new technology, people are probably going to freak out about it being a new technology and thinking about ways of communicating why, how the new technology works, why you should feel confident that it's safe. And so I think that's a lot of what you have to do, as well as, you highlight RSV is, can be as bad as influenza, but most people don't think influenza is that bad. People have lots of misconceptions about what the flu is. A lot of people think it's when you have a stomach bug or something, or if you get a fever, you've gotten the flu. And so I think that there's one of the challenges with kind of routine vaccines that we're familiar with is combating the sense of like, well, we already know what this disease is and what the vaccine does. And so I think that's one of the challenges with like existing vaccines that you don't have with kind of vaccines that are coming down the pipeline.
I think some of the ones coming out are diseases that people may not be as aware of. And you raised this earlier on, Aaron, it's that, what's the risk to me? I mean, how many people even know somebody who's had TB? Some of our older patients might, but many of us as healthcare providers have never even seen a TB patient. So that makes it a little difficult for the new ones coming out. Some people don't know, what malaria is. They've never, particularly in this country, we've maybe never seen it. So it's going to be raising that awareness. And that's where the risk communication is so important. Understanding that it could be a risk to you, but it's also the more you get immunized, the better it is for everybody else around you.
Oh, I want to get back to a point that Barb made earlier about, addressing people's, kind of informational concern, but recognizing that there might be something deeper behind that. And that's also one of the focuses of my KO1 is that the idea that a lot of times I think, the reasons people give for not wanting to get vaccinated is just kind of like a superficial reason why they don't want to get vaccinated. And so I'll be exploring kind of psychological traits or motivations or needs that might be underlying, resistance to being vaccinated, and then trying to then kind of leverage those insights to develop better vaccine communication. So just as a kind of like very crude example, a number of people don't get vaccinated because they're scared of, getting jabbed with a needle. And so a way of leveraging that would be to highlight the number of, jabs and sticks you would get if you get hospitalized with influenza or with COVID or the disease, so that might be a way of kind of leveraging kind of the need and concern about that, and then flipping it to be more pro vaccine than pushing them away from getting vaccinated.
Aaron, I think that's a really important point for everybody to remember. We often do just get that superficial, and I'm going to say socially acceptable excuse. It's the same with exercise. I always laugh. I don't have enough time to exercise. Like, seriously? Let's talk about how much time you waste all day. So it really takes that one-on-one going deeper, which when we do community-based education, it's a little harder to get to, but it really is taking that time, looking the person in the eye and saying, tell me a little bit more. You're afraid of the shot? Well, let's talk about how we can make it easier. Or I'll go with you and hold your hand. And I'm not gonna lie to you, truthfully, the shot doesn't hurt as much as it's gonna hurt you after, if you really wanna know the truth, but we're gonna get through it. And so it is that honesty, that trust, and getting to the real truth of the matter.
So as I hear you talk about trust and honesty and open communication, it all sounds great. And I wish I could have one of you on my shoulder when I'm talking to some of my vaccine hesitant patients, including some of our veterans who have like these great big tattoos, but still don't want to get another needle in their arm. I joke them through it sometimes. So as I think about populations that are underserved or have not been treated well by our society or by our healthcare system, how do we get those groups on board to trust the medical system and to accept vaccines? What are your thoughts for that? And Aaron, we'll start with you.
Well, I think engaging with those communities is key. And we've talked about how we need to build trust with these communities, like the African-American communities, and that should have been happening well before the pandemic, because by the time that it gets to the point of, trying to get groups to get vaccinated who might be, hesitant to get it, it takes time to develop trust, and you don't have that time necessarily. And so I think, obviously working with leaders within those communities, hearing, being open to hearing their concerns and taking them seriously, and recognizing that for some groups, they have completely, it's completely understandable why they might be concerned, like the African-American community and, their history of how medical testing and things like that. And similarly with, you brought up veterans, which I think is a really interesting group, because a lot of veterans, when they're in active duty, have to get vaccines that are, maybe more experimental, like, the anthrax vaccine. I've heard a lot of veterans complain about how they felt like guinea pigs because, they were forced to get the anthrax vaccine. There might be effects from it, and so they tweak it and then, administer it again. And it seems like for every kind of cohort of veterans, there's something weird that happens vaccine wise. So, during the Vietnam War, they did what's it called? It's like the air pressure shots. And there's a huge rate of hepatitis C among baby boomers, and it's even higher among veterans who are baby boomers. And so a lot of those veterans thought it was because of the way they were injecting the vaccines, when in reality it had to do with, they were at higher risk of intravenous drug use, and that's why they have higher rates of hepatitis C. But so part of it is just understanding like historical context, so that you can kind of have empathy towards where they're coming from, and so you can engage in them in a respectful and empathetic way.
Barb?
Yeah, so I would say that, some of the tricks of the trade that we've done is to get role models, people within those communities, certainly that can be trusted. I think it's also thinking, Aaron, about ways that you can, I won't say quickly develop trust, but what are some of the things you can do to develop trust? And you mentioned them. It's really listening to the concerns and making it easily accessible, beneficial to them. What's it going to do for me? What's it going to do to that individual and that community? And it's never giving up. You can't go in once, it's going to take time. And I think, you know, everybody wants the quick pill to fix it. There's not a quick pill here. It's time, it takes development, but it can be done.
Interesting. You're speaking to me when you say that, because I do just want to fix it and get everybody a vaccine so I don't have to have them get sick. You know, like, here, this is your quick pill. But yeah, it's an interesting dilemma to be in, isn't it? So as we think about different aspects of where our older adults live, we've got nursing homes, which are both residential and skilled nursing facilities. What about some of the assisted living and senior housing? How do we get our vaccines into that population? Should they go through their primary care office? Should it be something that the building offers somehow?
So I can jump in. I do a lot of work in assisted living, and I think that really depends on the site. You have to remember with assisted living, first of all, it varies state to state, but it's also the size. If you have a little bitty 3-bed facility, you're probably not going to bring vaccines in, right? You might bring people out. You might be able to get some done in-house. So I think that's a big factor, but I also think that partnering with pharmacies, we had to do the same thing in continuing care retirement communities to get large groups of independent living older adults immunized, to really bring it to them, to make it truly accessible and to know we were getting everybody immunized. So I think that is an important thing to address and think about, whether or not you make it policy. We have those issues going on, and many organizations are. There are some that aren't, and it's all over the place. But you make it policy and you change behavior. Now, the behavior change may be that that person leaves their job, but at least you're keeping your community safe. So they're really tough things. And then truthfully, from an implementation perspective, it's really using, again, very much the theoretical based approaches I talked about, as well as some implementation theory, which would be getting maybe a stakeholder group within that community to work with you, identifying a champion or champions to serve as the ones that are going to beat that immunization song until no one wants to hear it anymore, and just give me the shot so I don't have to listen to you, which is the point we want to get to everybody. Again, never stop asking, never stop doing it. And you can make it happen in these communities, but it takes a team.
I have a feeling that you are that champion for your area, which is awesome.
I grow the champions as well. You have to grow the champions.
Yeah, that's one of the things that blows my mind, is that, you know, without external pressure, you know, vaccination rates among healthcare workers is about the same as the general population.
It's worse.
Yeah, or worse.
Worse.
So it's like, that's crazy to me that people who are trained in the area of medicine and healthcare, you know, again, it gets to the point that information is necessary, but it's not sufficient for changing behavior. So yeah, it's crazy.
So some of it is nurses who see the impact of immunizations. If you see one thing bad happen, they hold on to it. So again, it's getting at those beliefs, dealing with them, and trying to, you're trying to get the positive outcomes up and the negative outcomes down so that you win that weight, that scale.
Yeah,
But
and
nurses are the worst.
that's gets to a good point in terms of the power of anecdotes and personal experience versus statistics. Our ability, our brains have only developed for the capacity to do statistics within the last, a couple of 100 years that we've really had formalized statistics. And so it's a recently acquired skill, whereas, responding to our environment is how we survived in our kind of evolutionary past. And so, anti-vaccine groups have been really effective at using anecdotes and just like, having stories about kids who are, adversely affected by vaccines, and kind of the public health and medical response has been statistics, which doesn't really move, it doesn't really move people very well. So
We all act on not what we know, but what we believe.
yeah.
And
what
sometimes you have to read something and hear it many, many, many times before you will come around to believe it. And again, that gets to my point of never stop trying. On those veterans, Robin, that one that just won't do it, keep at it. You may win.
I'll go back tomorrow.
Yeah.
I have to say it's a joy to work with that population, and yeah, they're special, and it's really fun. So as I hear you talk about the stories that the anti-vax movement will tell, it's like they appeal to our primal fears, like it's the boogeyman stories, and that's what we have to fear. So for both of you, and Dr. Vesnick, we'll start with you. You want to emphasize the positive. So what stories do we tell, or how do we emphasize that positive to overcome those kind of innate fears that are sometimes being communicated?
So I would find out what the fear actually is. Is it fear of pain? Is it fear of getting the disease? And then you're going to hit it based on that. And I shared a little bit of some of the things I would do related to pain. I'm not going to lie. The shot's not that bad, but the impact of that shot may be pretty uncomfortable. And honestly saying, it's not the end of the world. It's going to hurt for a day or two. We'll give you this, we'll do that, and address it. So I think addressing the fear head on is the best way to deal with it. It may be, many people may fear they're going to get COVID if they get a shot. Again, no, we could talk to your blue in the face that there's no evidence to show that. You can share, I think sharing personal stories is helpful. And then maybe talking about what, how many patients I've taken care of with COVID and what the impact of that is versus, gosh, I've seen thousands of people have been immunized, and if anybody's had anything, it only lasts for 24 hours. So we need to hit the fear head on, and don't let that fear just be that top, don't just take the icing off the cake. Get down to the cake, because they're giving you the first fear is the one that's socially acceptable. You want to dig deeper. So what else worries you? And sometimes a way to get that out is to share, even if it's not true, white lies, particularly in geriatrics, are okay. But to say, I was really afraid that I was going to get an infection. I have really little arm. I was afraid it was going to hurt. I was afraid of this. I was afraid of that. But to share your fears sometimes helps somebody share their own. So get at the root of it, and then just try and address it best you can. And then the next time they come back, address it again.
Yeah, there's a technique in clinical psychology that's starting to be used to address people with low vaccine confidence, called motivational interviewing. And essentially it's focused on asking open-ended questions, listening in an empathetic way, trying to repeat back to the patient or the parents kind of what you hear them saying, and then really trying to elicit what they're, what they value and what their goals are, and then kind of situating vaccination within those goals and values. And so that gets to kind of, what Barb's been talking about, where, it's really listening to the patient and trying to get to that deeper issue, and then helping them work through that, so that the motivation is rooted in something, they need to find their own why they want to get vaccinated. And so motivational interviewing is kind of one way of helping them get to that point of wanting to get vaccinated for personal reasons, not just because Barb's been harassing them about it for the 100th time. Although if that works, that works. So.
So thank you both for a fantastic discussion and for a great series of questions and answers and a really good conversation. I want to remind our audience that there are references and resources in the chat. And now we can open this up for audience questions as well. All right. Thanks, everybody. And we're now at the live portion of our momentum session. So I'll start off by thanking again to Aaron and Barb for a great presentation and a lively discussion. So there are a few questions that came in on the chat. And one of them is, I think that Aaron, you actually addressed both of them, but I think it's worth discussing a little bit more. One of the questions asks about political orientation to predict vaccine hesitancy and how we might tailor those messages.
Yeah, so obviously there has been political polarization around COVID vaccination. I do some political psychology research, and I've never seen like a political attitude change as quickly as I've seen attitudes change about COVID vaccination. Because, early on, there was a big difference between where Democrats were more likely to get vaccinated once one became available compared to Republicans. And then President Trump started advocating for vaccination, and the gap closed where Democrats said, oh, well, now we're not going to get vaccinated, whereas Republicans were. And then, now with President Biden, that gap has reemerged. And there's been a number of attempts, including research I've done, trying to tailor messages towards, more conservative oriented values, such as like security and freedom and things like that. And at least what I did and I've seen hasn't been overly effective. And so I think really, it's going to get down to what Barb was talking about. It's building a relationship of trust with the person, or ideally you already have that, and just having those conversations. I don't think any sort of public health messaging campaign is likely to change someone's mind if their opposition is based on political or religious ideology.
I also throw in there that I think it's a shame to put people in buckets. Whether you're a Republican, a Democrat, black, white, purple, green, short, tall, fat, skinny, male, female, it comes down to individual reasons. And usually it's not one reason. So it's a little scary to just assume because you're of this group, you're not going to get vaccinated for this reason. So I really encourage that more individualized approach. And as we said at the beginning, there's not one pill that's going to fix this all.
So less about us and them, but more about all of us together trying to work on this problem that we all must face. Okay, that's a wise perspective. Thank you. So something else I wanted to ask you both about is the idea of vaccines that we get to protect ourselves, like shingles vaccine. compared to vaccines that we get to protect ourselves and others like influenza and COVID. How are you experiencing that as you talk to individuals, and what are you finding in the literature and research for that? So Barb, we'll start with you, please.
From my perspective, it's how you motivate.
Okay.
So it varies. If it's individual like shingles, I think it's obvious. Showing people what shingles is, helping them know, helping them understand that it will help them not get the disease. Tdap, I think, is a good example of a vaccine where we give it more so that the individual can protect their grandchildren or great-grandchildren. And so it's really more around the motivational technique for me, and drawing on, like with COVID's great because it's both personal as well as community, and you have that opportunity to pull on the altruistic value of immunizations. Likewise with flu, likewise it will be with RSV.
Yeah, and just one thing I'll add is, research and psychological research on vaccinations has provided some evidence that appeals to altruism are going to be most effective in more individualistic cultures like the US versus more collectivistic cultures, because they're already thinking about the group and the group's well-being. But even then, I think you get differential effects. In surveys I've done, there's about an equal percentage of people who say, they get vaccinated to protect themselves versus, they want to do it for others. So, yeah, again, it just kind of depends. As Barb said, it's not one size fits all kind of thing.
Yeah, lots of challenges here. What about some of the differences, or maybe I should back it out a little bit. We talked about this a little bit in our discussion earlier. What recommendations do you have for all of us to be better at cultural competency so that we can address some of the vaccine hesitancy among racial and ethnic minorities? So Erin, we'll start with you on that one, please.
So there were, I'll say one thing is that, at the beginning of the pandemic, we were really concerned about, non-Hispanic, Black, and Hispanic Americans getting vaccinated. They actually, are getting vaccinated at the same or higher rates than whites now. And among those people who haven't gotten vaccinated, about 3 in 4 white Americans say, they're definitely probably not going to get vaccinated, versus like 50% of those who haven't gotten vaccinated among Black and Hispanic Americans say, that they probably won't. So obviously we typically think of this as needing to be culturally competent, when in reality it's, almost kind of the opposite problem that we typically have. But I think just, being sensitive to their concerns. And, obviously with the African American community, and there's a legacy of kind of abuses in medical research, obviously with things like Tuskegee and stuff. And I think part of it, as I highlighted, is building confidence in vaccines rather than trying to necessarily just address misinformation or distrust, and really trying to take a more positive approach. And that might be, it'll obviously involve asking them kind of what their concerns are, and then trying to build a positive case from there, I think.
Thank you. And we have one question that's coming in from the audience that asks, lots of minority adults are not in assisted living or long-term care. How do you ensure they have the same quality of care compared to those in long-term care settings? Barb, do you want to take a stab at that?
Well, I would say really it's getting to communities where those individuals will live. I know I do some work, for example, in senior housing. there tends to be low income senior housing, where there tends to be a lot of older adults that are within different minority groups. So I think it is reaching out there. And I think it's critically important to make it easy and accessible as just a blanket. If you can't make it law, also make it easy and accessible, because that will help. And I would say also, I mean, I just firmly believe in the individual approach, because no matter who or what you are, there's a lot of crossover about the reasons why we do and don't do a certain health behavior. I found that with exercise, and I see the same thing with immunizations.
All right, so we are at the very end or the top of the hour. So thanks to both of you. Thank you to GSA, and thank you to the sponsors for our momentous discussion. And thank you also to the excellent GSA staff, and also to our audience and participants. I really appreciate the good questions and your attention, and take care, everyone. Thank you.
Bye.